welcome everyone in attendance today. This is ReavillMED's presentation of Dr. Marik and the vitamin C protocol versus the Surviving Sepsis Hour 1 bundle. The presenters today, I'm Matt Reavill. I'm the president of ReavillMED. I'm the inventor of the ReavillMED catheter. And our guest today is Dr. Paul Marik, who's the creator of the vitamin C protocol. And we'll get into that in a little bit. Let me first cover a few things about sepsis. 1 million hospitalizations occur in the U.S. because of sepsis. Up to half of these half of all hospital deaths are sepsis related. In the United States, sepsis kills more than prostate cancer, breast cancer, and AIDS combined. Sick patients are 8 times more likely to die during their hospitalization. The issue with blood pressure cuffs and why blood pressure cuffs do not detect death by sepsis is the reason we're going to talk more about ReavillMED. Sepsis death is caused by organ failure, and that's the sepsis starting with the major organs, starting with the kidneys, and the cascade of events. And the problem is that those dying organs are not detected by healthy blood pressure because the dying organs feed into the heart. The heart regenerates the blood pressure, and what you read with a blood pressure cuff is it can't show you the dying organs. The problem is that the one organ that isn't dying is the heart, and that's what you're measuring with a blood pressure cuff. The blood pressure cuffs are measuring the one organ that isn't failing, and that's the heart. So the reliance on these devices is counterintuitive to treating sepsis. The dying organs will only affect the blood pressure going into the heart, and that's not the side being measured. This pressure is called central venous pressure, and what you're seeing there, if you can see my mouse, you're going to see that the dying organs feed the inferior vena cava and sometimes the superior vena cava, and that pressure reading is called central venous pressure. And if it's below 4 millimeters of mercury, that's indicative of septic shock on its way. And you can see that the healthy blood coming out of the healthy heart is going to be normal, which you can't measure with blood pressure cuffs. ReavillMED is the premier contracted supplier for measuring central venous pressure. We have a breakthrough technology that allows you to infuse in a catheter through the IV line and measure central venous pressure. It's reimbursed $1,150 via CPT 93503. It's available to you on your premier contract as PPNS 1044. Again, all you have to do is trim this device and hook it up to your peripheral IV, and you can measure central venous pressure. No risk of central line related injuries. It is a breakthrough. It's a 2017 premier breakthrough. This is a handy little device that you can add to it. It's also available on your premier contract. It is contract PPNS 1049. It's the Compass device from Medline. And this device hooks up to, it's called the Compass Universal. You can hook it to the ReavillMED device, and you won't need a monitor to read central venous pressure. You can just hook up this device on your right to your IV line, and you'll have central venous pressure. No monitor needed, and then your reimbursement as well. So the important point for that is that if you can measure central venous pressure before you do the 3 bundles, whether you do the CMS required bundle, the Hour 1 bundle, or the Marik protocol, if you measure central venous pressure before and after, you can tell whether the protocol you're using is having an effect. You can also complete the protocol because you've taken these critical measurements. And this has been attributed to Deming, but you can't fix what you don't measure. That said, let me cover the three bundles that we're going to be talking about here today. Obviously, this is the CMS core measure. This is the biggie. Only 49% of hospitals comply with this. It is supposed to be completed within 3 hours, and that's the first steps. And then back when this was written in 2016, I believe, they had the 6-hour bundle and a definition of severe sepsis. Those have all been changed. We're wondering whether they're going to update this bundle, and at this point we don't know because the Surviving Sepsis campaign has issued the Hour 1 bundle, and they wish all to be changed to 1 hour. And that's everything done immediately and right away. And there's been a huge resistance to this. And we ask hospitals that if you're going to choose a protocol, you do your bundle across the hospital, that everybody's in agreement about what you're doing, and then you follow your bundle to the letter. But if you're not going to follow these bundles, then you need a good reason why you're not following it or what your new bundle is. And that leads us to the Marik protocol. This is by far the simplest of the three, and the new one that's getting all the attention. This is the Marik protocol, and you're going to hear from Dr. Marik himself here in a second to detail that for you. It's my honor and privilege to present Dr. Marik. He is the current professor of medicine and chief of pulmonology and critical care at Eastern Virginia Medical School in Norfolk. Dr. Marik has written over 400 peer-reviewed journal articles, 50 chapter books, and authored 4 critical care books. It's extremely an honor to present Dr. Paul Marik. Thank you.
Thank you for the introduction, Matt, and hopefully everybody can hear me. So what I'm going to be talking about today is hydrocortisone, ascorbic acid, and thiamine, or HAT therapy, for the treatment of severe sepsis and septic shock. I'm in fact not going to be speaking about the Surviving Sepsis campaign update of 2018. In fact, the Society of Critical Care Medicine has last week placed a moratorium on their own guideline, instructing people not to follow or not to introduce the 2018 guideline. So you figure that one out. So before I start, I just want to say there are, as you'll see in my talk, only 2 medical interventions which in randomized controlled trials have been shown to improve the outcome of patients with sepsis and septic shock. And those are 1, steroids, and 2, vitamin C. And as I will present, the assumption is that both of these together will work better than each individually, and we do have data to support that. Next one. So I really don't have any disclosures, and I do not own any stock in vitamin C or hydrocortisone. So sepsis is a global problem. The burden is probably more than 40 million cases per year. The mortality in resource-poor countries is about 60%. The mortality in the U.S. runs about 30%. It's the commonest cause of death in children, about 5 million per year. Sepsis kills more Americans than AIDS, prostate cancer, and breast cancer combined. This is data from the CDC. In addition to being one of the commonest causes of death, patients who survive sepsis suffer from the post-sepsis syndrome, which significantly interferes with the quality of life. They have both physical and cognitive impairment. So, as we said, about 300,000 people die from sepsis each year. Sepsis survivors have a shortened life expectancy, an increased risk of major adverse cardiovascular events, an increased incidence of cognitive dysfunction and post-traumatic stress disorder, impaired quality of life, and are 42% more likely to commit suicide. In addition, sepsis is the most expensive hospital diagnosis in the U.S. It costs, this is data from 2013, it costs the U.S. over $24 billion, costing more than myocardial infarction and heart failure combined. So obviously there are enormous human costs and enormous financial costs associated with sepsis. It's important to realize, and this was first explained by William Osler, that except on few occasions, patients appear to die from the body's response to infection rather than from it. And this is really an essential concept to understand. If one exposes the human genome to endotoxin, you have the altered expression of over 3,500 genes, which then alter the transcription of an enormous number of proteins, which then interact in an exceedingly complex network. So you can see this is exceedingly complicated. So just to summarize how we currently understand the pathophysiology of sepsis, and as you'll see how it becomes important. So we have bacterial antigens being processed by toll receptors, the production of NF-kappa B, an important transcription factor for pro-inflammatory cytokines. This results in increased expression of enzymes that increase production of reactive oxygen species. Reactive oxygen species then damage the mitochondrial transport proteins as well as the Krebs cycle. So as you'll see, the prime pathophysiology in sepsis is mitochondrial injury, abnormalities of a Krebs cycle with decreased energy, ATP production, and the cell goes into a state of hibernation. This concept was well described in 2002 by Mervyn Singer and colleagues, who looked at tissue ATP production, which was significantly decreased in patients who died from sepsis, and then this was correlated with your complex 1 of your mitochondrial electron transport chain. So the question is, why patients with sepsis die? The prevailing thought and the concept that's perpetuated by Surviving Sepsis and other groups is that patients die from microcirculatory failure and tissue hypoxemia. However, there's no data to support this concept. In fact, cellular O2 often goes up. The prime reason patients die from sepsis is bioenergetic or metabolic failure. Now, in terms of treatment of sepsis, we know that there have been over 100 phase 2 and phase 3 clinical trials that have all failed. And as you can see this list, the general approach is to target one protein or one pathway, which is obviously a very simplistic approach due to the enormous redundancy of all the enzymes in these pathways. So simply blocking one enzyme is unlikely to have any biological effect. So this was articulated by Dr. Aird. The best hope for therapeutic advances in sepsis will depend on broad-based targeting in which multiple components are targeted at the same time. And this really goes against the current pharmaceutical approach in which they try to target one specific enzyme or receptor or protein. In addition, we know that every single element of the Surviving Sepsis campaign has been shown to be invalid and not supported by any level of evidence. Indeed, this study demonstrates that early goal-directed therapy, which formed the foundation of the Surviving Sepsis campaign, actually increases the risk of death in those patients with the highest severity of illness. So we're going to talk about the cure. So I believe that sepsis is a curable disease. Patients do not need to die of sepsis. And when I say this, people laugh at me. But you'll see that there's a lot of truth in what I have to say. You know, we can't cure patients' underlying disease, whether that be leukemia or advanced heart failure, but patients should not die of sepsis. What's important to realize is that there's steps to the cure. We're not suggesting that you just give our metabolic protocol. There are a number of really important steps, and probably the most important is early diagnosis. This is the most important aspect of the treatment of sepsis, is early diagnosis. Following this, early administration of the correct antibiotic in the correct dose. Following 1 and 2, we need source control. If you don't have source control, you're not going to control the infection. So that may be removal of an intravascular catheter, drainage of an abscess. If a patient has a kidney stone and pyelo, you need to drain the kidney. Following that, a conservative physiologic approach to fluid resuscitation, which must be individualized. Having a single protocol which is used in every single patient is clearly absurd. Followed by the early use of norepinephrine, because basically sepsis is a vasodilated state and fluid actually exacerbates that vasodilatation. Then, as we said, patients die from cellular metabolic failure, and therefore we use hydrocortisone, ascorbic acid, and thiamine as part of the resuscitation and metabolic resuscitation protocol. It requires multidisciplinary team approach together with state-of-the-art evidence-based supportive care. This is a paper which was published 2 days ago, which basically shows the changing paradigm for the treatment of antibiotics, treatment of sepsis. You can see at the top is the traditional approach. You give antibiotics, you then give massive amounts of fluids when the patient's not responding to fluids. You add pressors, and then you add stress dose steroids when the pressors aren't working. So we're suggesting a completely different paradigm in which you start antibiotics early, limited fluids, but at the same time you start vasopressors to limit the amount of fluid, and then you start your metabolic resuscitation immediately at the same time. So how did this all begin? Actually, this goes back to January 2016. And this was our first pivotal case, which led us on this interesting journey. So I was in the ICU, the attending. We had a 53-year-old female who presented with altered mental status in the emergency room. She was clearly hypotensive, BP 47/20, tachycardic, febrile, jaundice, tender right upper quadrant. She had a high white cell count with a bandemia, increased creatinine, increased lactate. Her procalcitonin was markedly elevated. We'll come back to this. So procalcitonin at 59 is highly suggestive of gram-negative sepsis. She had altered liver function tests. We did an ultrasound and CT in the ER, which showed acute cholecystitis. She was immediately started on Zosyn and vancomycin and rapidly admitted to the ICU. In the ICU, she had escalating doses of pressors. She was then found to be fluid non-responsive. She was intubated. She had a PERC cholecystotomy tube placed immediately for source control. The patient was in renal failure, so continuous renal replacement therapy was commenced. We did a markedly decreased ejection fraction, which previously had been 55%. I was aware of the work that Dr. Fowler from VCU was doing with vitamin C. So I thought, well, let me give this a try. In addition, I obviously had a long interest in the use of corticosteroids. Postulated that possibly these two drugs, which have similar profiles, may be synergistic. At this time, I had no evidence, but this was just a hypothesis. So we started this patient on vitamin C and hydrocortisone, and you can see this is her 3 blood pressure medication profile. You can see within hours of starting vitamin C and hydrocortisone, there was a rapid de-escalation of her vasopressors, and within 18 hours, she was off all vasopressors. Just to keep in mind that the average duration of pressor dependency in sepsis is about 54 hours. Day 2, pressors were off. She was extubated. Her urine output improved. Day 3, renal replacement was stopped. The blood cultures grew E. coli and Clostridia perfringens, which are obviously really bad organisms in the blood. Her EF had improved to 40%. On day 4, she was transferred to the medical floor. So this was a patient who was admitted in septic shock with multi-system organ failure. She left the ICU on day 4 with no residual organ failure, and she went home day 8 to return for an elective cholecystectomy. This is a picture of the patient with her consent. Obviously, she did really well. So based on our first 3 cases, I thought, maybe we were onto something. So I published this editorial in Critical Care Medicine. You can see the same year, 2016. I thought we had an obligation to make people aware of this intervention. So the philosophy behind HAD therapy, so the goal is to target the host response to infection rather than the infecting pathogen. So we were looking for agents that are both anti-inflammatory and antioxidant. We wanted to use multiple agents with overlapping and synergistic actions. Most importantly, they needed to be safe with no side effects and cheap and readily available. So I'll briefly go through our study, which was published in Chest. Most people are aware of it. I'll go through it quickly. So this was published in Chest in 2017. As it illustrates, this was a retrospective before and after study. The treatment group of patients who were treated prospectively over a 7-month period. These were consecutive septic patients. It should be noted that when we started the study, we only enrolled patients who had severe sepsis, as indicated by a procalcitonin above 2, which generally cuts the sepsis population in half. The control group met the same inclusion criteria in the previous 7 months. There were 47 in each group. The patients were pretty equally matched. You can see in the treatment group, the average vitamin C level was 14, and as we'll see, this is diagnostic of scurvy. Every single patient was vitamin C deficient. As we know, there was a pretty dramatic reduction in mortality in the treatment group. Reviewers wanted us to do propensity adjustment, so we did propensity adjustment according to the propensity to get vitamin C, and you can see again the odds ratio for death was 0.13. Just remember this number as it will come back again, 0.13. This is the time to discontinuation of presses using a norepinephrine equivalent dose, and you can see in all patients on presses there was a rapid discontinuation of presses. And as I said before, the mean duration of vasopressor dependency in the literature is 54 hours. Shows the SOFA score in time in the treated patients and in the control who lived and control who died. So there obviously the treatment had a major effect on organ failure. People were concerned about the renal function, and as you can see, there was a rapid decline in the serum creatinine. This shows lactate, and as we have postulated, the problem in sepsis is bioenergetic failure with inability to use pyruvate, which gets shunted to lactate. So you can see the dramatic effect that the intervention has on serum lactate levels. This is the procalcitonin. This is a semi-log scale, and this is an absolute predictable finding that in the treated group, the procalcitonin falls by 50% each day. It's absolutely predictable and reproducible. This was the conclusion of our study. Our results suggest that early use of intravenous vitamin C together with steroids and thiamine are effective in preventing progressive organ dysfunction, including acute kidney injury, and reducing the mortality of patients with severe sepsis and septic shock. I've highlighted the most important phrase, which was often ignored, which said that additional studies are required to confirm these preliminary findings. As many of you know, the social media and foam got hold of our paper and it went kind of viral. The impact on social media was kind of interesting. It was very bimodal. Most people thought this was very cool. However, the established medical community thought this was snake oil, fairy dust, or just crap. This is the skeptic's guide to emergency medicine, basically saying don't believe the hype, and there's a list of 11 people who critically refuted every single aspect of our study. This is from Dr. Simon Finfer from Australia. This is one of more of his amusing comments. So the cartoon says, I killed the person. What did you get sent here for? And that's me. I said my observational trial was so good we didn't need a randomized controlled trial. And clearly that's not true, and I never said that. However, the comments of Dr. Finfer actually became exceedingly vicious and very personal, as did many of his colleagues. So this is from some of his tweets. It's snake oil quality evidence. No funding body would touch. Historical controlled trials always crap. Crap news articles don't equal science. It amazes and worries me that people genuinely think these data mean something and are strong enough to advocate treating patients. First, the argument that it can do no harm is intellectually destitute. There are loads of things that we don't think harm patients until we study them properly. There's also the harm that results from getting our nurses to spend their time giving useless treatments. So he was speaking on behalf of the International Sepsis Forum. So just to answer the last question, we've treated over 700 patients and probably over 500 worldwide, as well as a randomized controlled trial, which you'll see there's not one single report, not a single report of any harm, any side effect, or any complications from this totally and utterly benign intervention. And that we can say absolutely with absolute confidence. We've even studied patients who have oxalate stones and hyperoxalosis, and remarkably their serum oxalate goes down. What's most troubling is this is the Surviving Sepsis Campaign Research Priorities for Sepsis and Septic Shock that was published earlier this year. Vitamin C is not mentioned once, not once in this paper. This is the Second World Sepsis Congress put on by the Sepsis Forum. And again, you can see this was recently in September. Vitamin C and our protocol was completely and totally ignored. So there is the other side to the social media. Clearly what's happened is there has been a change over time. This is from a talk that Dr. Corey gave, and I found this on Twitter. So we can see Marik published a paper showing a 30% absolute risk reduction in septic shock. First thought, holy shit. Second thought, some other major practice change occurred in his ICU that explained the results. Third, they compared apples to oranges, the dummies. Dr. Marik is a fraud and cherry-picked data. And then finally, he uncovered a physiological truth, which is clearly what the answer is. So this is, as I said, probably over 500 patients have been treated worldwide. And I get emails daily from physicians and patients. This is from Josh from New Hampshire. Neat case right now in my unit, elderly man with ischemic cardiomyopathy, EF 15% at baseline, presents to outside hospital with shock, given 2 to 3 liters of fluid as per surviving sepsis, immediately went into respiratory failure, shipped us intubated on 4 presses with acute kidney injury, eventually ended up growing group B strip from his blood with a procalcitonin of 43, started the cocktail. Within a day, his pressure requirements melted away and he was extubated. His kidneys have improved. He's walking around the ICU. Tomorrow he will probably leave the ICU with no residual organ dysfunction, no volume overload, and no complications, which is exactly what we see every day. So I got a telephone call from Gerald's sister. She called me Gerald. This is from South Carolina. He received chemotherapy and was septicemic. He was semi-comatose. The doctors had given him 3 days to live. The doctor says it's in God's hands. Nothing could be done. She asked me about the protocol. The physicians begrudgingly decided at her request to give it, although they said it's complete and utter nonsense. This is Gerald 24 hours later. And I think a picture is worth 1,000 words. So the evidence mounts. This is a study recently published as an EPUB, Intensive Care Medicine. This is a group from South Korea who did a before-after study looking at vitamin C, hydrocortisone, and thiamine in patients with pneumonia, i.e. they try to reproduce our study. You can see this is their survival benefit. You can see the difference between the survival. The top line is the treatment versus the bottom is the control. Propensity adjusted risk of death, 0.15, which is almost exactly what we found. So in fact now this is an updated meta-analysis looking at the 2 observational studies and 3 randomized controlled trials, 1 under review, and you can see they all align perfectly and show an odds ratio of 0.3. So if you want to assess the efficacy of an intervention, you can use the number needed to treat. The most effective intervention known to man is defibrillation for VFib arrest. You can see odds-net is you need to treat 14. So using that data, how effective is this protocol? Number needed to treat is 4.2. So this happens to be one of the most effective medical interventions known to medicine. So this is a study out of Australia, completely independent of us. They looked at the potential cost saving of our protocol, and they calculated at $74 billion. So that's $74 billion over a 5-year period, and would save 1.9 million quality adjusted life years, and with a 98% probability. So if you actually talk about the cost of quality adjusted life years, it's actually a negative number. There's no intervention in medicine which actually has a negative quality. So you're actually making money by treating these patients. So just to briefly go through vitamin C ascorbic acid. That's ascorbic acid there. It's a simple 6-carbon molecule. It donates a single electron to form the ascorbate radical, which doesn't react. It's not a very reactive radical. It can then be converted back to ascorbic acid. It can lose another electron to form dehydroascorbate, and the ascorbate radical plus dehydroascorbate can then be reduced back to ascorbic acid, or dehydroascorbate can be converted to diketogulonic acid and then oxalate. This is the formulation that we use. This is the package insert, which says there are no contraindications to administration of ascorbic acid. It lists no side effects. Its parental administration is desirable patients with an acute deficiency, i.e. septic patients, and those whom absorption or oral ingested is uncertain, i.e. septic patients. 1 gram is recommended, however, as much as 6 grams can be administered parenterally. So indeed, we actually administered ascorbic acid exactly as per the guidelines of this package insert. More recently, McGuff Pharmaceutical has an FDA-approved vitamin C available for injection known as Ascorb. So ascorbic acid is made by almost all mammals or animals and plants, except for humans and guinea pigs, which lack the last rate-limiting enzyme, gulo, in the biosynthetic pathway. For example, a goat makes about 2 to 4 grams per day in its liver. When the goat is stressed, it increases production to about 6 grams. So it's indeed acts as a stress hormone or stress molecule. So ascorbic acid is an essential vitamin for humans who lack L-gulolactone oxidase the final enzyme in the biosynthetic pathway. Vitamin C acts as a free radical scavenger and, importantly, a coenzyme for multiple biological reactions. It's absorbed by the gut by a sodium-dependent transporter, SVCT1. It circulates in human plasma at a level of 40 to 60 micromoles. It's then transported into cells by a second transporter, SVCT2, and it reaches millimolar concentration. So it's concentrated in all cells except red cells at very high concentration. So this schematic shows the transport. On the left is SVCT1 absorbing from the intestine to the blood, concentration about 40 to 60. It's then actively taken up by most cells, reaches very high concentrations in the adrenal gland, and then it's taken up into the CSF and into neurons, where it reaches enormously high concentrations in the brain, and vitamin C plays an essential role in neurotransmission and neurological function. But this slide is important because it illustrates why you can't give vitamin C orally. So this was a pharmacokinetic study in healthy controls. And you can see, due to the saturatable absorption kinetics in the gut, once you give more than 0.5 grams or 500 milligrams, you do not get further absorption. So that there is limited GI absorption, and this is even further compromised in patients with sepsis who have abnormalities of the transporter, and that giving the same dose intravenously gives you significantly higher concentrations as it bypasses the saturatable transporter in the gut. As we said, all mammals except primates and guinea pigs increase vitamin C synthesis during stress. Vitamin C levels are typically very low in critically ill patients. Low levels are due to enhanced metabolic turnover, decreased GI absorption, and urinary loss. The data shows that actually 100% of septic patients are deficient, with 40% of patients having levels compatible with scurvy, i.e. exceedingly low levels. And these levels are low despite PO supplementation up to 1,500 milligrams a day. So it's not possible to achieve normal serum levels with oral supplementation. This table summarizes the roles of vitamin C in sepsis. There are probably over 50 basic science studies that have been done which clearly demonstrate the benefit of vitamin C in experimental sepsis models. The most important is the free radical scavenger, scavenging extracellular, intracellular, as well as mitochondrial reactive oxygen species. Indeed, vitamin C is actually taken up by mitochondrion. Secondly, it has potent anti-inflammatory effects. So these two really important. The other important role is it's a cofactor for the synthesis of epinephrine, dopamine, and vasopressin. And as we know, it's essential for wound healing. This is just one study that I selected which demonstrates a number of points. So the goal of this study was to demonstrate that vitamin C prevented cellular immunosuppression by preventing upregulation of Treg cells. However, what they did in this study is they took mice in which they knocked out the gulo gene, so they had gulo positive or wild-type mice and gulo negative mice. They then injected endotoxin, or this was a Zika ligation and perforation model, and they then gave vitamin C to two groups. So the bottom line is the gulo-negative mice. So these are mice who can't make vitamin C. You can see they have the highest mortality. Those mice that could endogenously make vitamin C had a reduced mortality. And then both groups of mice, gulo-positive and negative, who were given supplemental vitamin C, had almost 100% survival. And in the study, they did not give antibiotics. So I think it's a very interesting study which highlights the protective effects of vitamin C. So what about thiamine oxalate and vitamin C? This is a study by Dr. Danino. This was published the exact same month that we started our study. So after our first case, we added thiamine to our protocol. Basically, he showed that 32% of patients with sepsis were thiamine deficient. If you gave them thiamine, you reduce mortality. In a follow-up study, he showed that in all patients, thiamine reduced the risk of renal failure. And this becomes important because the prime cause of renal failure is bioenergetic failure. The kidney has the highest concentration of mitochondria after the heart, so it's highly vulnerable to energy failure. And they demonstrated that thiamine reduced the risk of renal failure. So thiamine plays an important role in Krebs cycle. It's a coenzyme for pyruvate dehydrogenase as well as alpha-ketoglutarate dehydrogenase. So thiamine is really important for getting pyruvate into the Krebs cycle and therefore generating hydrogen equivalents or reducing equivalents for the electron transport chain. Other important part of thiamine is thiamine's required for the metabolism of glyoxylate. If you're thiamine deficient, you tend to make more oxalate, hence the inclusion in our study. Synergy between steroids and vitamin C. There are a number of studies which demonstrate the synergy. This is a really interesting study. This is a renal ischemia reperfusion injury model in a rat, where they gave placebo, vitamin C, steroid, and the combination. And you can see the combination completely restored normal histological pattern, whereas vitamin C and hydrocortisone alone had a lesser effect. It's interesting, this paper was published prior to us starting a study, and we were clearly unaware of this study. This is then a study that we did, looking at the combined effect of hydrocortisone and ascorbic acid together and separately on pulmonary endothelial layer. And what we demonstrated is that LPS basically killed the monolayer, but if you gave hydrocortisone and vitamin C together, it preserved the tight junctions and the viability of the pulmonary endothelial cells. In summary, hydrocortisone, ascorbic acid, and thiamine for the treatment of sepsis. This is an exceedingly cheap, exceedingly safe, and what we think is an exceedingly efficient method of treating patients with sepsis. Unlike previous approaches, you can see from the slide that vitamin C, thiamine, and steroids act at multiple sites to actually interfere with the most important pathophysiological processes, which is oxidative injury and damage to the mitochondrial Krebs cycle and electron transport chain. So we believe there's a validated mechanistic basis. It's supported by basic science, supported by clinical studies. So what's next? So fortunately, this is from clinicaltrials.gov. There are currently 11 randomized controlled trials which are being conducted worldwide investigating the triple combination in patients with sepsis and septic shock. The biggest trial is the Victus study, which has just started, and this study is being supported by a philanthropic donor. The initial sample size is 500. After that, an interim analysis, the study will go to 2,000 if required. So the next question is, what's next? After what's next? So the question is can one perfect HAT therapy based on the basic premise, or the other simple, safe, cost-effective, readily available agents which one could add to this combination? So after much thought, thinking about this, much research, we actually think we can improve HAT. And we think the molecule is melatonin, which is a remarkably interesting molecule. It's completely safe. It's impossible to actually cause any side effects or injuries in an animal, no matter what massive doses are given. What's interesting about melatonin is that it is a specific mitochondrial antioxidant. It's the only specific antioxidant which directly targets the mitochondria. Indeed, there are transport proteins which concentrate melatonin in the mitochondria and protect the inner mitochondrial membrane and the enzymes associated with the electron transport chain. This is illustrated by this slide looking at complex 1 of the electron transport chain, again showing that melatonin increases activity, LPS markedly decreases activity, and if you get LPS and melatonin, it tends to restore complex 1 activity. So there we have it, MHAT, which we think will have a great impact on the treatment of sepsis. Thank you for listening.
Thank you very much, Dr. Marik. I love that. I think we can open it up to a little bit of Q&A if I can make this work. Is any questions out there that anybody would like to start out with?
Yes, David Brown here from Cambridge, UK. Hello, Paul.
Hey, David. How you doing? Sorry about the audio visuals didn't quite work out as planned.
That's pretty good, compared with most. My concern is publication. Do you think some of these big names that are opposing you could block publication of these studies?
Yeah, so that's a really interesting question. So, I think there are enough studies. There was a concern that in the Victor study that people would try and sabotage the data or the publication of the study. But I think there are enough studies being done with enough oversight
that that's not likely to happen. But clearly there are a whole bunch of people out there who do not like me, would want me dead, and would want our protocol dead. So, it's quite remarkable how the powers that be have been so completely silent at best and quite vindictive at worst. And I think, it's quite remarkable. And I can only assume because, as I said, in the U.S., this is at least a $23 billion industry. There are currently 1,700 clinical trials being conducted by on sepsis, many supported by industry. And the idea of finding a simple, cheap intervention is very disturbing to many people. So I must tell you, my first paper went to every single major journal and was rejected outright. So they did not like it. So you can go down the list of every major journal that rejected it. We were really fortunate enough that Dr. Irwin, the editor of Chest, was open-minded enough to actually look at this in a more objective fashion. So, time will tell. I think things are changing slightly. People are a little bit more open to the idea, but obviously time will tell.
Yeah, I'm reminded of the story of the lady whose name I can't remember, who first had the idea that mitochondria evolved from bacteria. Apparently she submitted to about 100 journals before she finally got accepted.
Yes.
Yeah, and that's just what happens. So I'm wondering, could it be that trials in, for instance, Japan, Korea, Australia, where there may not be the same opposition, or the UK where I am, might be a better bet than the US?
Yeah, so I think you're right. So, there's a randomized study in China. There's one in Greece, which is quite far along. There's one in Australia. So, I think if those studies are positive, and it will be difficult to question other studies. There's a study in New Jersey in the U.S. by a group of investigators that are really very believe strongly in this treatment. So I think there are enough people who believers who will honestly conduct the study and report the data. You know, it may not get into the New England Journal, but you know what? I think it will get somewhere. Which, you know, I think you can't suppress the truth forever.
I mean, given you're getting very high levels of efficacy here. No drug alone would ever achieve this level of efficacy in my experience, apart from the one I invented, of course, Viagra, which was highly effective. But that was very exceptional. We showed efficacy in just a few dozen patients, and it seems to me you can show efficacy here in 50 to 100 patients with reasonable levels of significance. So, what size studies are actually required? Do you believe if 10 studies are going to be done to prove this, what size would each study actually need to be, and what would the cost be?
Yeah, so that's a really good question. So the first thing about our study is we selected the sickest group of patients. So, these had a high procalcitonin. So these were patients who had the highest risk of dying. So I think the sample size would depend upon what patients you enroll. The mortality for sepsis runs around 30% if you take all comers. So I think the sicker the patients, the smaller the sample size. But I think a study of 200 patients, should show a very strong signal towards benefit, if not, survival. But,
my days of running studies, it was like $20,000 per patient. So that's still a lot of money, isn't it, if you need 200?
Yeah, so, that's the problem. It shouldn't cost that much money. Fortunately, we have a philanthropic donor who has quite a lot of money. I would have preferred to pay the sites to do the study rather than per patient, because I think when you pay per patient, it creates some incentives to enroll patients that may not be ideal.
Yes, you're right.
I wasn't involved in the Victor study. They didn't want me involved. They thought I would bias the results of the study. Anyway, it is what it is. We do have sufficient funding, for 2 large multi-center studies, because theoretically, the cost of the drug is not expensive, and administering it is pretty cheap. But I suppose you have to pay the manpower for screening and collecting data.
But as you said early on, this must be saving money per patient for each hospital.
Yeah, so if you look at the big picture, which is what astounds me, is that the amount of money it saves the health system is so ginormous. It's absolutely ginormous. You're talking about nickels and dimes, what it's costing. And, we know it at our hospital because our nephrologists are really pissed because they do not see acute kidney failure the way they used to. So their business of acute renal injury has gone down significantly. And obviously that's an enormous cost. So, it depends who's, people were making money out of sepsis, but if you actually look at a more global humanistic point of view, I mean, this can save a gazillion dollars.
Yeah, I mean, my view, I sent you the publication that I published just a few months ago on this, and my view is this is probably one of the biggest killers of humanity. It's up there with cancer overall, I think. In terms of morbidity and mortality, it may be top of the list.
Yeah. It certainly is, and I think people aren't aware of it. And one of the things which is even more worrisome is the post-sepsis syndrome. So, the people who leave the ICU are often cognitively and physically profoundly disabled. And I'm absolutely sure by shortening the ICU duration and by, limiting the risk of delirium, that that will be significantly decreased.
Yes. Okay, sorry, I've talked too much. I should let other people ask questions.
No, it's good talking with you.
Yeah, good. Thank you.
Thank you. Does anybody else have a question? Okay. Well, I guess we can go ahead and wrap that up. Thank you so very much, Dr. Marik. This webcast webinar will be on the Premier website. ReavillMED will have a copy. Apologies to those that were not able to get in on the call today. We will make this fascinating call available and very informative and a great new way to treat the #1 cause of in-hospital death. Thank you again, Dr. Marik, and the call ends.
Thanks, Matt, and thanks for those who participated. Thank you kindly.
Yeah. Thanks to you.
Thanks.
Goodbye.
Bye.